Clinical injections do not happen on the surface of the body. Every needle insertion is an exercise in depth targeting along a z-axis. The clinical goal dictates exactly which of these isolated layers the needle must reach. A slow-release compound requires a highly insulated environment, while a rapid-onset emergency intervention demands immediate circulatory access. The body's varying physical layers provide these distinct absorption profiles. Missing the intended layer alters the efficacy of the delivery. A compound meant for slow absorption will metabolize too quickly if injected too deep, or fail to activate entirely if delivered too shallow. To prevent these failures, early-stage clinical professionals build a rigorous mental model of human anatomy from the outside in. This structural model relies on 4 primary modalities: intradermal, subcutaneous, intramuscular, and intravenous. We're going to map exactly how these 4 delivery methods correspond to specific depths, tissue layers, and anatomical sites across the human body. Mastering this z-axis is the mandatory first step to translating biological literacy into practical clinical action. To organize these targets, clinical medicine utilizes a standardized summary matrix. Looking at this table, we see 4 primary injection types. Sequentially, these are intradermal, subcutaneous, intramuscular, and intravenous. Each type correlates strictly to a specific anatomical tissue layer. The matrix links these modalities directly to the skin, fat tissue, muscle, and a vein. Because these layers vary in thickness across the body, the depth requirements dictate the physical locations chosen on a patient. The target sites range from the forearm and upper back down to the abdomen and thigh. This matrix serves as a literal blueprint for biological architecture. To apply it in practice, we have to translate these rows and columns into a spatial, 3-dimensional anatomical model. Isolated data on a chart offers little utility in an emergency. A clinician maps this 2-dimensional table onto 3D patient anatomy to ensure safe delivery. We start at the uppermost structural boundary of human anatomy. The intradermal modality is the absolute most superficial injection type. The exact target here is the skin itself. An intradermal insertion is extremely shallow, approaching at a near horizontal angle to terminate right within this thin cellular boundary. The primary, highly accessible anatomical sites for this administration are the forearm and the upper back. Plunging deeper past the epidermis along that z-axis changes the environment entirely. This brings us to the subcutaneous injection. Subcutaneous delivery specifically targets the yellow lipid layer. The needle bypasses the epidermis entirely to terminate fully within the fat tissue. Common high-lipid anatomical targets for this method include the abdomen, the thigh, and the arm. Notice that the arm supports both intradermal targets on the forearm and subcutaneous targets. The difference is purely a matter of technique and spatial depth. The superficial layers, skin and fat, offer distinct, localized absorption environments that require precise calibration to navigate. Pushing beneath the lipid layer requires a longer needle and a new clinical approach. This is the intramuscular, or IM, modality. The target environment here is the thick, striated muscle tissue. Safely reaching this depth requires selecting locations on the body that possess significant, dense muscle mass. The specific high-mass anatomical sites utilized for IM injections are the deltoid, the thigh, the hip, and the buttock. The thigh serves as a highly versatile site, utilized for both subcutaneous fat injections and intramuscular deep injections. The z-axis depth of the needle determines exactly which tissue the thigh receives the payload in. IM injections require precise anatomical landmarking to ensure the payload clears the superficial fat and successfully reaches the deep striated tissue. At the deepest functional level of clinical delivery, we shift away from static tissue absorption and enter the active, rapid flow of the circulatory system. Intravenous, or IV access, is a direct injection strictly into a vein. By utilizing the bloodstream, IV delivery bypasses localized tissue absorption entirely. The primary targets for this systemic network are the hand and forearm veins. The antecubital fossa, inside the elbow, is a critical primary IV site. IV delivery is used primarily for large volume fluids, emergency medicine, and systemic antibiotics. These treatments require immediate systemic circulation to function. Direct venous access constitutes a complete mechanical shift from localized tissue delivery to immediate systemic intervention. Pulling back the analytical frame lets us view this complete biological cross-section in its entirety. Here are all 4 structural layers stacked simultaneously. skin, fat, muscle, and vein, with 4 distinct needles terminating precisely at their respective depths. This spatial architecture aligns directly with the data from our summary table. On the superficial level, intradermal targets the skin of the forearm and upper back, while subcutaneous targets the fat of the abdomen, thigh, and arm. Down in the deep tissue, intramuscular targets the mass of the deltoid, thigh, hip, and buttock. For systemic bypass, intravenous directly accesses the circulatory system through the hand, forearm, or antecubital fossa. Clinical efficacy relies entirely on exactly matching the appropriate chemical intervention to its precise corresponding anatomical layer. Mastering this spatial hierarchy and accurately mapping the Z-axis of clinical delivery is the absolute bedrock of safe,